We're back again. Bryan Anderson, Director of ActiveTracks, which is the sports medicine arm at CORA Physical Therapy. We have Ashley Langford, Director of Clinical Excellence at CORA Physical Therapy and the CORA Institute for Clinical Excellence. I'm Adam Goodrich on the marketing team at CORA. We are going to spend 5 minutes, I'm setting the clock, 5 minutes talking about the balance of vestibular and concussion, understanding the balance here, differences, similarities, etc. That was me lighting the fuse. Bryan and Ashley, take it away.
Bryan, I'm going to make a comment, and I'll let you. It'll pour gasoline on that lit fuse.
Gotcha.
If I'm a clinician and I know vestibular, but I have not taken any concussion training, I feel like I'm good enough. Like I can get away with treating patients effectively. I'm not going to miss things. What are your thoughts?
You're not going to miss vestibular things. You're going to miss 75% of concussion symptoms. So my thoughts are this. I think you need both, right? I think you need a solid vestibular foundation because with that same injury, there's obviously going to be insults to your vestibular system, right? Your ear canals, we can, VPVV, vestibular ocular reflex, all these things tie together, but it's only one part, right? So that may give you the dizziness that you feel during your concussive event, and that may be the only reason for the dizziness. Or it could be cognitive processing things. It could be balance issues. It could be all sorts of different things. So again, I think personally you need both. And when we do the training, there's a heavy foundation in vestibular and how to treat that prior to us moving into concussion things. And
okay,
honestly,
wait, Tio, I don't know what vestibular is. I know what concussion is. Give me the 30-second definition of vestibular and or concussion. Help me understand the difference here.
That's a hard thing to do because there's so much connection. Like if we're talking about vestibular, we could talk about your BPPVs where you've actually got a physical crystal, the otoconia that's broken loose. But that's only a small snippet of vestibular and concussion because you've also got like so much communication that goes on around that. Your VOR, your VCR, so the cervical, your eyes, and then of course, like we tie the brain in there, and you can see where like whether it's post-concussive or vestibular, it expands into a massive world. And Adam, that's a great question. If you go into it like a lot of clinicians seeing it as that BPPV, you're shooting yourself in the foot, right, Bryan?
Well, we say it all the time. If the only tool you have is a hammer, everything looks like a nail, right? So I say if you're only vestibular trained, everything's vestibular. A short answer to your question, so vestibular is your ability to input information, right, from your environment and react to it, right? So whether it's hearing, vision, all that stuff, it's that ability to do that gets disabled in some way. Concussion is actually that disability resides in your brain, right? Because of the movement or the shearing or the axons in your brain. So again, I know I've used this term before, but a processing error. Now that can mean so many different things, but it includes vestibular, right? So you can have concussion symptoms inputting and processing information in the same way. So sounds and vision and all that stuff is a heavy part of concussion and vestibular, right? So when we talk about both of them, it's info in and then output. Right? So information in or stimulus in and then output or reaction to it. Somewhere vestibular, it's getting messed up, and same thing with concussion.
Okay, so but knowing how to treat one doesn't mean knowing how to treat both.
No, absolutely not.
And do they go in order? Does it go?
So I actually teach, so we actually have a track where we start with the neck. So we say always clear the neck, because if you have a whiplash motion, you're probably gonna have neck pain. And honestly, neck pain can give you migraine headaches, can give you sensory integration problems, can give you just from having neck pain and headaches. And you have no issues with your vestibular system or your brain or your concussive symptoms.
Dizziness,
so we always say start with the neck. Yep. We always say clear the neck first. Okay. And then it moves to vestibular. Okay. Do we have a BPPV? What's going on with this sensory information? And then you move on to our concussion specific things, cognitive. Actually, I think we have balance in front of cognitive, balance, cognitive, visuospatial attention, all of those things that are specific to concussion. So we do have a very, at least the way I teach it, we have a very strict kind of guideline of how. Now that doesn't mean you're not treating everything else. If you're treating neck, the triage is going to be on the neck if they have that.
And you each mentioned BP, BV, which is
benign
let you pronounce it.
paroxysmal positional vertigo.
I can never
Which
say.
is, yeah, which is the otoconia, the crystals in the inner ear of the circular canal. They're there and they're meant to be stuck in this gelatinous material, and for whatever reason they can break loose and they're in the wrong part of the ear. It just starts to make you realize how fascinating the body is, right?
Yeah.
But when we talk about vestibular, and concussion we know we can see and treat at any point in life, right? The average person, because as adults, we don't do much more than sit and stand. We don't challenge our vestibular system. So whether or not there's a trauma or an acute vestibular problem, the average person over a certain age is going to have a loss of vestibular function. So when we start talking about post-concussive at that later part of life, you better know how to treat vestibular, because that might be something you got to work through, just like balance.
Well, and
right.
vestibular takes care.
That's 5 minutes. That's 5 minutes. Final words, Bryan. Final words. Go ahead. Fire away.
Yes. No.
Ashley, final words. But that's 5 minutes. We did it. Go ahead.
No, both. Okay. So again, our theory is a solid foundation in vestibular and a solid foundation in concussion makes you an amazing clinician. Obviously, there's a lot of other things that go into that, but again, if you're talking about these dizziness type injuries or these input processing type injuries, you need both, and it works both ways. If you're treating concussions and you don't know much about vestibular, you're going to miss a lot of different, again, your patients aren't going to get better. And same thing with vestibular. You may be missing a ton of other things that can really help your patients.
Ashley, anything to add?
No, that was beautifully said.
Beautiful. All right. Rate, review, subscribe, and follow along for more topics like this one. Thanks, guys. Talk soon.